So, what's your best guess at the following conditions? And welcome to this week's webinar. Last time we looked at segmental facilitation. This time it will be reflex inhibition, which to my mind is at least as important as facilitation and may well have more profound though more local effects. The concept of reflex inhibition has been around for some time, but has been popularised by the Australian therapists with regard to spinal segmental instability. But it does also occur in the periphery, and we'll be looking at the subject in principle, which of course applies to both spinal and peripheral issues. This webinar will address the characteristics of reflex inhibition, its causes, the assessment of it, and its effects and its treatments. Reflex inhibition is best described or defined operationally as shown in this slide. Clinically, you will find all of the above to a greater or lesser extent. But because the severity of reflex inhibition will vary from case to case, as will the sensitivity of the tester, a minimum must be found to claim reflex inhibition is present. The other issue is that reflex inhibition is often found in concert with segmental facilitation, and the two can be confused as a single entity. In my experience, reflex inhibition dominates the picture locally to the cause, while segmental facilitation effects are seen in a segmental distribution, that is, non-locally. Removing what reflex inhibition isn't and its cause, we are left with the positive clinical findings as an operational definition. The distribution of these signs is local to the cause of it and is not in a segmental or neurological distribution. Hypotonus is found in the muscles affected, and of course this is local. The type of weakness is very characteristic. It is a sudden breaking of the contraction when resisting an eccentric force. It is less obvious if you are eliciting a concentric contraction. The weakness is also patterned and is almost always a PNF type of pattern. Finally, inputting proprioception into the causal joint results in increased strength and tone, but unlike facilitation, which responds to input from anywhere in the affected segment, reflex inhibition will only respond to local wobbling. As always, it serves you to remember that a model is probably not a truth, but simply a way of visualizing a phenomenon to help understand and deal with it. Reflex inhibition is muscle inhibition reducing both the muscle strength and tone. This does a few things, including loss of motion restricting power and subsequent increase in the neutral zone or dynamic restriction of movement at a joint or a segment. It also permits greater range of physiological movement of the joint by decreased tone. So it increases both physiological motion, hypermobility, and non-physiological motion, instability. This is well documented in the spine, where it is in whole or in part the cause of segmental instability. This slide shows a process when reflex inhibition is initiated by pain inhibition from an injury, decreasing the range of motion, which, if it persists long enough, allows the chronically reduced proprioception to produce reflex inhibition, so that even when the pain is gone, the inhibition remains. This inhibition tends to be directional because the pain and range of motion loss tends to be directional rather than omnidirectional. The hypotonicity allows the neutral zone to increase, which further reduces proprioception, leading to further inhibition. Eventually, the neutral zone allows the end zone structures to be encroached upon and chronically stressed until they break down, giving rise to end zone instability and sometimes pain and dysfunction. Overt trauma, or microtrauma usually, as in chronic sustained or repeated low-level overstressing, can lead to a sequence of hypermobility, instability and subluxation with consequent decrease in proprioception followed by reflex inhibition. The second method of chronic sustained injury seems more likely than a single trauma, as few people can remember such an onset of pain severe enough to cause either pain inhibition, as in the previous slide, or a single incident end zone instability. To add to the model, I would speculate that there are at least two types of reflex inhibition, primary and secondary. If we look at the spine as an example, the primary inhibition would be that of the segmental muscles, the multividae, etc. The secondary muscles would be the abdominals, both the obliques and the transversus. If you test the strength of rotation with flexion and extension, you will almost invariably find that either flexion and one rotation or extension and one rotation are weak when forced to resist an eccentric contraction away from a full range position. For example, if the patient was weak as you push them from a flexion left rotated position into extension right rotation, there would be a breaking weakness of the flexor left rotators. But if you tested the flexor left rotators from the extended right row position concentrically, there is no weakness. In both cases, the same muscles are being tested, flexors, left rotators, but only with a breaking contraction is weakness found. That is, eccentric contraction of these muscles is weak, but not concentric contraction. Therefore, the muscles are fine, but the position is not. A possibility is that the strong contraction into extension right rotation causes arthrokinematic slipping that in turn inhibits the muscles. You can see this in every part of the spine, but the upper thoracic spine is interesting. Here it is the shoulder rotator muscles that are weak when they are tested from end ranges of elevation, lateral rotation, elevation, medial rotation, extension, lateral rotation, extension, medial rotation. One of these will be weak if you test them with eccentric contractions. Wobbling the thoracic segment that is in trouble improves the strength of the shoulder muscles. I've written this too simply for what you may actually see. This is what happens when only one segment is unstable or only one direction is unstable, but multiple segments or directions of instability will result in more movements being weak. And you can sort this out by wobbling one segment at a time and retesting movements afterwards. The neurophysiological exam for reflex inhibition consists of eccentric stress testing from an end range position, followed by assessing the tone. For reflex inhibition, we are looking for a distribution of strength loss local to the causal joint and patterned in PNF diagonals. In the spine, hypotonicity is most easily found in the multifidus, rotatories and suboccipitals. Less easy to feel for is tone in the secondarily inhibited muscles such as the abdominal, sternomastoid and extensors, and it is possible but unlikely that tone loss does not occur in the spine. It's just that it may be very difficult to feel. That there is tone loss is more of a speculation based on the clinical fact that tone loss is easily observable in the peripheral muscles undergoing secondary inhibition, but not in the spine. However, there's no good reason not to expect the spinal muscles to react the same way. But it really doesn't matter whether you can appreciate the tone loss or even if it exists in the large trunk and neck muscles. It doesn't matter clinically. They are certainly weak when tested eccentrically. The peripheral muscles are assessed in the same manner as the spinal, that is with eccentric contractions from an end range, and the findings are the same when reflex inhibition is present. After finding and assessing the degree of strength and tone loss of the joint or segment, it is wobbled first anywhere in the segment from which the muscles are derived, or at least the joint over which the muscles are running are derived, for 5 or 6 seconds. And if there's no response to that, locally the wobble is carried out. After the wobbling, comparative assessment is carried out and reflex inhibition is confirmed when there is improvement with local wobbling but not segmental wobbling. By the way, I'm deliberately using the term wobbling for proprioceptive input to separate it from more formal joint mobility tests, as there is no reason to grade the wobbling or even the direction of the wobbling. But it must avoid producing discomfort or pain. Mainly, we are interested in reflex inhibition in order to identify possible etiologies for the condition that brought the patient in to see us in the first place. For example, weakness of muscle may lead to tendinopathy, reduced tone to increases in the neutral zone both in the spine and periphery. To identify reflex inhibition, I would suggest the following steps. Test the muscles around the joint of interest for breaking weakness, then test them for hypotonicity. Establish the distribution of the weakness and how it is patterned. These steps will establish the presence of reflex inhibition. You can then input proprioception by wobbling the putative joint, and if there is a partial or complete recovery, then you have confirmed the presence of reflex inhibition, and also have a prognosis on how well you're going to do rehabilitating it. If wobbling the joint doesn't improve things, then wobble the other joint over which the weak muscles pass. If neither improves the findings, then either the muscles are atrophied and unable to recover, or more likely, something else is causing the issue, and this may be a neuropathy. So look again at the distribution. The last part of this particular webinar concerns differentiation of segmental facilitation from reflex inhibition, and both from neurological issues. Segmental facilitation can cause problems at the joint due to the weakness it causes failing to protect the joint and limb structures when functioning at the end of range, while the hypertonicity produces an abnormal axis of motion which can act as another ligament and produce abnormal stresses through the joint itself and so damage the joint. Reflex inhibition can cause problems by its hypotonicity, increase in the neutral zone of the joint, and as a feedback loop it will get bigger and bigger. And so the dynamic support of the joint is lost. On top of that, there is weakness caused by reflex inhibition, which in itself allows it to not prevent the joint from moving too far, again operating at the end range and so allowing damage to occur to the end range structures. When searching for the etiology, it can be difficult to determine if the segmental facilitation or reflex inhibition is a cause or an effect. They can do both, and your problem now is determining which is which. With segmental facilitation, the problem is not as critical as it is with reflex inhibition, because segmental facilitation being caused by nociception and pain, once you rid the patient of the pain, you've certainly lessened the amount of segmental facilitation that's going to be present, and possibly even eliminated it, although you can't tell whether or not nociception is still present, except by stressing the joint. If it's still sore, then it probably is still nociceptive, and there may not be an awful lot you can do about that over the short term, and it may just take time to recover from that. Reflex inhibition, though, requires treatment because it isn't based on the amount of pain the patient's having, and extensive rehabilitation is probably necessary for long-term improvement. Failing that, there's going to be ongoing biomechanical treatment and the use of electrical muscle stimulation to get anything like a long-term product. The first step to rational treatment, though, is to try to determine if the patient has reflex inhibition or segmental facilitation or neurological problems as well. Once you've figured that out, you can deal with it appropriately. If it is a neurological problem, though, then it needs further investigation, because the problem has to be specifically diagnosed and its cause defined, and that really means referral out of your clinic to a neurologist. Okay, so let's look at an examination flowchart, if you will, for the etiology of the patient's problems. We start in the black box top left and we find weakness, or we don't. If there is no weakness, then neurophysiological can be disregarded, at least for the present, and we head to the right with hypothesis 1, or H1, being mechanical stresses as the etiology. If there is weakness, then we have various prognoses that you can make: reflex inhibition, segmental facilitation, or neuropathy, including, of course, radiculopathy. If the weakness is fatigable, then H1 must encompass neurological causes, and if this is true, you should find other neurological signs and possibly symptoms to accompany the weakness. If so, H1 is true. If no other signs, you may have a very atypical neuropathy or a very atypical neurophysiological cause. So go back to this as H1. If this weakness is non-fatigable, H1 equals neurophysiological cause. If the weakness is breaking, then H1 can be refined to either H1.1, reflex inhibition, or perhaps for clarity's sake, we'll call it H2. You should now find hypotonus. Only wobbling locally is effective and no neurological signs are present. If the other signs of reflex inhibition are confused or absent, it's probably that reflex inhibition is overlaid by segmental facilitation, or less commonly neuropathy. If the weakness is non-breaking, then H1 equals segmental facilitation, and the signs for this should be found. That is hypertonicity, absent scratch reflex, brisker DTR, which is not always easy to gauge, and wobbling anywhere in the segment is effective. Again, if the picture is confused, then segmental facilitation is probably overlaid by reflex inhibition. So I hope this and the previous webinar has given you a taste for segmental facilitation and reflex inhibition. I'll try and put a lot of supplementary materials in with this because this is very much a brief overview. But next time we'll look at how both conditions can be caused and cause tennis elbow. and how we're going to sort our way through these conditions when we look at them as an etiology, and also come up with a rational program to treat them. Until then, take care. Things are happening out there, and be careful of them. And I'll talk to you next week. With A, there would have been little significant change in the appearance of the foot for some time, except perhaps for a little more swelling from time to time as the pain came and went. The ankle would be stiff both chronically and on examination, and there's a good chance you'll be able to palpate thickening of the ankle capsule. B is either Sever's disease, calcaneal povositis, or retrocalcaneal bursitis, or any of its aliases. If it is a deformity of Sever's, then it's been there since childhood, and it would be bone. C is a nodule caused by rheumatoid arthritis, and D is bursitis, which may also be caused by rheumatoid as well as other things. On appearance, it's difficult to see the difference, but the difference, of course, is going to be with palpation.